Welcome back to episode 9 of the Vet Wrap. And today I have the lovely Dr. Susie Travelo.
Nailed it.
Practicing here today, and we're talking about urinary incontinence.
I'm Susie, obviously, and I've just recently become a fellow of the Australian College of Veterinary Sciences. So just passed my fellowship exams this year. I did my medicine internship and residency at Peninsula Vet Care, and I also used to work at one of the general practices before all of that, so been here a long time, I guess. So I am now one of the specialists in the medicine department, and I really enjoy all sorts of workups. I think urinary incontinence is often a fun one because especially the young dogs, they're fun and we can get some really good outcomes. And then all the other stuff. I think you guys were just talking about PUOs, and
we were.
It's spring, so it's PUO season, so getting a lot of those too.
Yeah, awesome. Great. Well, we decided we wanted to talk about urinary incontinence because we see it a little bit, and as you said, particularly the young dog ones can be lots of fun. So before we get started, I thought just a little bit of background. So obviously urinary incontinence, by definition, involuntary leakage of urine.
Yes.
And in case vets out there aren't aware, the Journal of Veterinary Internal Medicine came out with a consensus statement on this last year. So it's published, I think, December 2023 on diagnostic approach and treatment management of incontinence. And so that's a really useful resource if anyone out there in GP or otherwise is looking for some reading. What I like about it is it details kind of mechanisms of incontinence, which is always helpful, I think, when we're thinking about our differentials and prompting ourselves to think about our differentials. It then has some nice lists of differentials, diagnostic approach, treatment approach. It's a really handy resource.
Yeah, the diagnostic approaches I find really useful because you can kind of check it off as you go, I've done that, that can't be that, can't be that. It's really good.
It's really good. And there's a questionnaire in there as well. So they actually have a questionnaire for prompting you for questions that you should be asking the clients.
Yeah.
Or you could even print that and hand that to a client. So I think that's pretty handy as well.
Yeah.
And I'll put, we'll put a picture of that up there in post-production so that people know what we're talking about. It's really fancy and cool. But for today, what I thought we would do would be run through some cases. So, Susie, we'll start with our first case. Warm up the laptop.
Some flashbacks to exams now.
Ooh, scary. So putting you in the situation where you're dealing with, so you're seeing a 20-week-old golden retriever, and she's presenting, so female, entire, she's presenting for incontinence, so dribbling or leaking urine, and frequent urinations as well. So what I thought might be good is if you could talk through, I guess, are there any relevant history or physical exam things you'd want to know, but then thinking about differentials and how you're going to move forward through this case?
So I guess with these ones, getting an idea of how often they're leaking urine and what situations. Is it just at night? Is it all the time? Are they urinating normally? Because sometimes with certain neurological things, they won't ever urinate normally, or if they've got some very strange congenital anomalies, they won't urinate normally at all. They'll just dribble constantly, and the owner's actually never seen them urinate, which is, once you point it out to them, they realise it's quite odd. Then I also sort of just general basic health questions, because if we're dealing with something congenital, have they got other symptoms that could indicate something more systemic going on? Are they a runty dog? Could they have a liver shunt? Anything else like that. So just your basic health questions, vomiting, diarrhea, and then more focus on the urinary tract, like how often are they dribbling? Do they void normally? Are they straining when they void? That could indicate like a lower urinary tract infection or something else. And then also and then I'll start in with a physical exam, obviously, normal steps of an exam. And I'll focus on really, is there any sort of neurological dysfunction as well? So I might also perform a neuro exam with these ones just to make sure that there's not anything else going on that should point me in a different direction away from the urinary tract. I'll examine the vulva. Very rarely do you see anything other than it might be a bit moist. They might have some dermatitis around it. Usually in these ones, if we're heading down the track of thinking this might be an ectopic ureter, which would be one of the top differentials from the signalment you've given me, a bit of an easy throw. So if we're thinking ectopic ureter, I'll be usually recommending that we do a bloods and urinalysis if they haven't been done already, along with the urine culture, because often if they've got incontinence, they'll be a bit more prone to getting urinary tract infections. And if we're going to do urological interventional procedures, we want to have that under control before we do those. The other thing is with ectopic ureters and other congenital issues, bloods are useful because we want to look at renal function. Some of these dogs will have renal dysplasia or might only have one kidney. So knowing how much kidney function we have before we go in is really useful. That being said, bloods and urinalysis might not pick up if, they've got some minor renal dysplasia, and we might only see that on imaging, and it's not the end of the world. So those are sort of the basic stuff. And then sometimes I'll do a bladder ultrasound to start with and a kidney ultrasound if I'm a little bit worried, before moving on, usually to advanced imaging like CT, to look at the structure of the ureters, because ultrasound you can often see them because they're dilated and abnormal for an ectopic ureter. And you might find other issues like ureteroceles or bladder diverticulums, other things that could be going on or causing the incontinence. But CT just provides a great overview of the anatomy, and much easier to see everything. We can also see if the ureters are intramural, meaning that they're tunneling through the muscle layers of the urethra, or if they're extramural, so it's kind of coming in and implanting further down in the urethra rather than in the bladder. So once I've done CT, assuming at that point we've ruled out, we usually see the ectopic ureter on CT, but not always. And we've ruled out a lot of things at this point, like other causes of PUPD, lower urinary tract infections, a lot of other congenital abnormalities. And if I'm a bit unsure after CT, I'll perform a contrast retrograde vagino-urethrocystogram. Basically, in layman's terms, it's where we, under pressure, do a retrograde study by inserting a catheter into the vestibule, and then we inflate the bladder and urethra with contrast or diluted contrast so that we can actually see everything. It's another way of just getting an idea of the anatomy. And with ectopic ureters in particular, oftentimes because they don't have a normal orifice or opening, you can actually send dye back up the ureter and you see that it's abnormal and dilated on where it's inserting in the urethra. So that's something that you could do in general practice, but usually we use that as well as CT to help the surgeons plan if we need surgery. And then after CT, this is all done under one anaesthetic for these little guys. We do a cystoscopy, so looking up the urethra and in the vagina with a camera. And that allows us to locate the ectopic ureter opening, where it is in the urethra, and we can also help us determine if it's intramural, again, burrowing, or extramural. And that's really important for treatment in these guys, because if it's intramural, so tunneling through the muscle, then what we can do is use a laser via the cystoscope to cut the inner aspect of that ureter and make the opening form in the bladder. So we basically cut along it very carefully and slowly, and then until we're in the bladder, and then the urine empties into the bladder like it should. And if we do it right the first time, which sometimes it's a little bit of trial and error, but if we get it right, then that is all fixed in one procedure, is the goal. Sometimes it's two, depending on how things lay out, but nothing ever goes quite to plan. And then, so that's sort of how things progress, and that might all be in one procedure, or it might be a couple of procedures, depending on the case and that. So, and cystoscopy also allows us to pick up subtle congenital abnormalities that perhaps we miss on CT, and even those retrograde studies like, really unlucky dogs with like vagino-urethral fistulas or fistulas with the colon. They're really, really rare, but obviously quite important to pick up as well. Yeah. I think I went quite far away with that. But
no, you did. You gave a great run through, to be honest. So, I think, cystoscopy is really, really helpful in these cases, as you've made very clear.
Yeah.
Do you, and I think this is very important as well, like so many of these dogs actually do have some other underlying congenital malformation that could be contributing to incontinence as well.
Yeah.
Short urethra, dysplastic urethra, very frustrating. I guess, one question someone might ask is like, you've kind of already answered that, but like, if we are doing ultrasounds in general practice, do you think it's likely we're going to be able to pick up urethral?
Some of them you will see, because the abnormal ureter, it might be one or both, can be quite dilated because it doesn't have that normal sphincter, so urine pools just hasn't formed normally. So you'll see like a dilated tube that doesn't have blood flow, and it goes beyond the bladder. But if you don't see that, it doesn't mean it's not there.
Yeah.
You can use Doppler flow focus on the bladder neck to see if you can see both ureteral jets. And that's something I might employ more in a young male dog with incontinence, because a bit harder to investigate.
From a cystoscopy perspective.
Yeah, from a cystoscopy perspective. That's, again, it can be challenging in those circumstances, because if you don't see the jet, are you like, oh, is it just, I haven't got quite the right angle? Or if you see both, it doesn't mean there's not another opening in the urethra. They can do all sorts of crazy things.
Yeah, and they can have fenestrations as well, where they have like an opening in the bladder and then there is still that tunnel and then there's more going downstream.
They can be quite tricksy.
Yes, they can. So I think, cystoscopy is considered the gold standard for that reason, because you can sort of...
You can see
what's going on firsthand. Do you use... we're very lucky because we've got CTs and it provides like that beautiful three-dimensional image, better ability to understand if they're intramural or extramural. But if you were ultrasounding, would you use frusemide?
That's a little cheat. You can make those ureteral jets really, it's for the impatient sonographer.
Yes, or the smart sonographer.
It just means that those ureteral jets will start firing like really regularly. So that's in a dog that I think maybe doesn't have an ectopic ureter, and I just want to confirm that. Even metatomidine has some diuretic properties. So because frusemide is a diuretic, it just makes them produce urine a lot more quickly, and they, you see those jets much more frequently than if, a sedated dog might have reduced urine production. So it's just a little tip. That's a good one.
No, it's a good one. It doesn't mean that you're not sitting there for ages with the Doppler on waiting for the jet.
And it means that if you miss it the first time or you're just off, you don't have to wait 10 minutes for it to go
come back again. Yeah, exactly. All right. Well, yes, I did invent this little girl with the idea that she has an ectopic ureter, and the more likely event, which is it's intramural, which is more common. So just say she's a candidate for laser and we do that. What kind of conversation do you have with the owners about, I guess, outcome?
Yeah, it's a tricky one because owners are obviously always looking for a cure. And I think the really important with these ones is setting up that owner expectation that we get an improvement in the majority, say 50 to 60%. Have an improvement in their continence, and that's where that ACVIM score really comes in handy. So you think, look, you wear a score, I think it's out of 4 or 5.
Yeah, the incontinence score, trying to provide some sort of semi-objective quantification of incontinence.
You wear a 4 or a 5, and now you're a 3 or a 2, but you'll still have some leakage, and that's because often in these female dogs, as we've discussed, the anatomy is just not formed properly. So the musculature that keeps dogs continent is weakened, and they have urinary incontinence still. But for those ones that still have urinary incontinence, so that might be over, 50 plus, we then add in medical management as you would for any USMI case. So that's urethral sphincter mechanism incompetence. So that might be your still bistro. I usually tell owners if they haven't already spayed the dog to wait a season or two because that can really help. So in those dogs that are still entire, I'll probably go to an alpha agonist like phenylpropanolamine or propylene and see if that helps with continence, and sometimes dual therapy. So that will get you to sort of 70 to 80% continent dogs with like a fairly good continence score. For the dogs that have really ongoing, quite severe incontinence, we do have a final surgical procedure, which is the artificial urethral sphincter. And I'm not going to pretend that I know how that's put in, but basically it's a balloon that goes around the urethra that the surgeons implant, and it has a port in the dog's thigh that we can access to inflate that balloon around the urethra. So it's an artificial sphincter. So we can then inflate that. And it is a little bit fiddly getting it just right amount so that the dog can urinate but isn't dribbling. And it does need topping up throughout the dog's life. But for a young dog, that its only problem is the incontinence, and we've fixed the ectopic. We have had a couple where we've put these in and they have a really good quality of life. Like once it's in, yes, there's the post-operative recovery, but after that they come in, every 6 to 12 months, just put in a little drop of saline, keep it inflated. They do really well. Yeah.
Yeah, I think it's management of these guys can be really rewarding. As you say, we can't guarantee that just addressing the ectopic ureter is going to result in continence. It will, without doing it though, we will have a permanently incontinent dog.
Yes.
So no amount of medical management is going to sort this out.
Yeah.
And I do have that conversation with owners as well, because there's some owners that I think get a bit put off. It's like, if you can't guarantee a fix, I don't want to do it. But it's like, this is an important procedure to do. Let's get through it. We should improve things, but we have
and it reduces
more that
the risk of like getting the pyelonephritis. So we're taking away that risk from the dog, because these dogs are at risk of that if we, other than just the constant UTIs from linking, but that abnormal ureter.
And multi-drug resistant UTIs, having recurrent UTIs from a young age and multiple exposures to antibiotics. That's a nightmare to deal with as well. I think that these cases can do well. But, as you said,
the owner's got to be committed. It's a big undertaking for someone who's just got a new puppy. And it's a challenging conversation. Everyone wants to think they've got a perfect puppy, but it's hard telling people still perfect, but just slightly defective.
Slightly.
Yeah.
Well, that's a good one. That's a nice, sort of classic.
Yeah, and for just touching on the extramural, I suppose, ectopics, the ones that aren't burrowing, we can't use the laser for those ones.
Yes.
Because if we did, we would just open the ureter into the abdomen, which is not ideal.
It's not desirable, no.
No. So for those ones, they do end up going to surgery. But similar, there's not really any difference in outcome for intra versus extramural. And likewise, there's actually nothing preoperatively that anyone's been able to find that can tell us which dogs are going to have the best continence outcome. Because I think that's something owners will always ask, like, but what about my dog? Like, what do you think the chances are? It's like, it's still that 50-50, sorry.
Yeah, we have to remove this known source of incontinence and see what we're left over with, really.
It's nice when you fix it though, like for those 50% where they are mostly fixed, you go, oh, that's really good.
And if they can have laser, clients really like it, because at the end of the day, it isn't like an open.
Yeah, it's not a big surgery.
It's not a big surgical procedure. Obviously, they have a little bit of downtime, non-steroidals. Sometimes they will be completely continent for the first 2 weeks because they have that little bit of swelling and inflammation, and that kind of bulks up their urethra a little bit. But generally speaking, it's a good procedure for them to have done.
And also it removes that temptation to spay them at the same time as surgery, because I think we used to do that quite a bit, is we go in and fix the ectopic and then de-sex the dog while you're in there. And now knowing that the estrogen can be helpful in urethral development, kind of remove that temptation, keep the surgeon's hands away from things.
Yeah. Doing other more fun things.
Yeah.
So laser's a bit more of a fun procedure, I think.
Yeah.
Probably.
Yeah. Everyone likes lasers.
That's right.
Yeah. They're exciting.
Very cool, very fun.
Yeah.
Nice.
So then I think we were talking about we'd go on to another case. So now I get to
quiz me.
It's not really a quiz. Yeah. It's more of I'll give you a scenario. A case that I had, I think earlier this year or maybe late last year. It all blurs together. But it was a 3 or 4 year old male D-sex boxer, and he'd had repeated episodes where he would get quite distressed and be stranuric and just dribble urine during these episodes, and it would be kind of constant. He'd be walking around kind of like, oh my God, look really distressed, very uncomfortable, dribbling urine and straining. You could see him straining as well, posturing to urinate. The referring vet had tried a number of medications. I think he'd had a couple of urine cultures as well, which were negative. But it seemed to sort of ebb and flow, these symptoms. So sometimes he'd urinate perfectly normally. Other times he would have these episodes for multiple days in a row. Obviously quite alarming and distressing for the owner. So I thought it was a really good case to sort of discuss incontinence in male dogs and how you would approach those, because they're different.
Yes. I think this case is different to the former in a couple of different ways. Obviously it's a male dog, which is, as an incontinence presentation, is less common. But this dog is also straining as well. And so referencing back that consensus statement, I think, again, a useful framework for thinking about incontinence is, as they put it, we could be dealing with an issue with storage or an issue with voiding. And for this dog, I guess, because we've got straining, I'm going to be thinking, is this an issue actually with voiding as the dribbling incontinence a part of that, because the dog can't empty its bladder. There are little bits of urine that are just sort of overflow dribbling there, and that we've got some sort of issue with the voiding process. And then when we're thinking about issues with voiding, we're then thinking about, is this a mechanical obstruction or is this a functional issue in this dog?
I think the ACVIM consensus calls it moo and foo.
Yes, moo and foo. So moo for mechanical and foo for functional. Yeah. Really rolls off the tongue. Yeah. So for this dog, so asking a few more history questions, I guess we might be thinking a little bit about, it sounds like this has been going on for a little while and there's been some drug therapy and things, but just say it's presented new, it's going to be like, well, has this dog had any issues with urinary tract disease before, particularly things like stones or urinary tract infections? Any history of abnormal gait, paresis, ataxia, changes in behaviour, any issues with faeces or fecal incontinence? Because we do have to think about, apart from, our mechanical obstructions, like things like stones, tumours, prostatic disease, other functional disorders might be things like neurological disease in this dog. Yeah. And typically with neurological disease, we would generally expect something else going on, like an ataxia or paresis, fecal incontinence, though not always. So I'm going to ask those questions. Then thinking about my physical exam, again, like you did for your dog, I'm going to include a neurological exam. In this boy, a rectal exam is going to be important. Yeah. Feeling the prostate.
Can also be important in females. You can sometimes feel a urethral tumour.
Absolutely, yes. Yeah. No, a rectal for incontinence or any urinary presentation we should be doing a rectal, because palpation of the urethra is...
But in boys in particular.
Boys, yes, super important. Feeling for any back pain as well. So those are going to be the first examination things. The other thing is feeling how big this dog's bladder is. If this is an acute presentation, this dog could actually just have a urethral obstruction from a stone, and that's obviously a very acute pressing issue that we need to know about and evaluate. Other parts of the physical exam, observing the dog urinate is going to be useful. So take that dog out for a walk. Mm-hmm. What is it doing? Is there any issues with it actually posturing to urinate, or is it posturing normally? And then what sort of stream is it producing? Is there any discoloration or blood? Another fun little thing that we can do is, once we've taken that dog out for a walk, given it plenty of opportunities to urinate, bringing it back inside, and if we have an ultrasound available, trying to get an understanding of its residual volume in its bladder. Because if we have a lot of urine retained in the bladder, despite being given ample opportunities to urinate, by definition we have a voiding disorder. Yeah. And we'll pop it up in post, but this consensus statement does include how to calculate urine residual volume from ultrasound.
Yeah.
So it's basically taking your ultrasound image of the bladder, getting a length measurement, then I'll typically then go that 90 degree, get that orthogonal view, get a width and a height in centimetres, multiplying them by each other and then by 0.52.
That sounds familiar.
Yeah. Sounds about right. And then that should give us a volume of the bladder approximately in mils.
Yeah.
And we would expect for a normal dog, they should have less than 1 mil per kilogram of urine in their bladder after voiding. If it's in the 1 to 3 mils per kg range, it's a bit of a grey zone. If it's more than 3 mils per kg, then this is urinary retention.
I think the ones that I've had, it's usually fairly obvious, even without the measurement. You go,
yeah, you just put the blood probe on, you're like, that's a big bladder. So you can get academic about it if you want. Another option would be to place a urinary catheter, which might be necessary in this dog as well. And obviously if there's a big pretty stone in there, then you'll know what the problem is, but that can also be obviously used to measure urine output.
And just for this one, just because I remember this case, because his problem was intermittent, asking owners to go away and film the problem. If you like take the dog out for a walk and it's urinating totally normally, but then the owners, obviously they can tell something's wrong some of the time. There's a lot of value in sometimes just getting them to get that video so you're not flying as blind.
Yeah.
And you're questioning whether there's actually anything going on.
Actually a problem there, exactly. So videos are super helpful. The invention of smartphones I think has really helped us out
really
quite a lot
the
actually.
Industry, yeah.
Exactly. So then moving on from that, so maybe, I'm in the position now, I think this dog has a voiding disorder. What am I going to do? Blood work, probably, is still relevant in this case, even if the dog has a straight up urinary obstruction. Does it have a post-renal azotemia? Is it really hyperkalemic now? These are things that we probably want to know about.
Yeah.
Urine testing is relevant. Again, maybe, this dog also could be presenting with a bacterial cystitis or prostatitis. Just say it's actually voiding completely normally and it's plaqueuric and straining because it's painful, but getting a urine sample and looking for a urinary tract infection is going to be high on the priorities list.
And I think also not even as the cause of it, but if you've got a voiding disorder.
Yes, absolutely.
You could just have a secondary UTI.
Yeah.
And you're going to want to treat that again before you.
Or you could have struvite urolithiasis and that's actually also part of it. So, a urinalysis.
Yeah, I think you should do it. Back yourself.
Thank you. So urine testing should form, part of any urinary workup.
Yeah.
And then moving on to imaging. So there's lots of tests we could do here. Plain radiographs, looking for your radio opaque stones. We can complement that or make sure we include the urethra in that view, pull those legs forward so we get the perineal sort of aspect view. Doing a contrast cysto-urethrogram, like retrograde, also going to be very helpful. The challenge with male dogs is we have limited capacity. This is jumping a bit far ahead, but to scope the entire penile urethra. They're quite narrow.
Especially in a smaller dog.
But we can put a little urinary catheter in the tip of the penis and inject contrast and see is there a luminal abnormality there or a stone tumour.
So stricture.
Stricture, especially if this dog has a history of, prior urinary tract obstructions. And then, of course, we can complement all these things with ultrasounds if we are worried about prostatic disease, getting a good look at the prostate to see is there a mass, is there a big cyst, etc. So imaging is going to be, really important. Yeah. For this case, if we get to the end of all of that and there's no stone, no infection, no tumour, no prostatic disease, then we might be thinking about, it's a sort of adult, large breed male dog. Could we be dealing with something, and this is not particularly common, I think I've only seen one case, reflex dyssynergia, where we actually have, this is one of our FOO, our functional.
There's not many FOO.
There's not many FOO. And actually, if you read this consensus statement, this is the idiopathic FOO, really, the big one that they talk about, where we basically have abnormal coordination, I guess, between kind of bladder contraction and relaxation of that urethral sphincter mechanism, such that the dog is basically contracting down its urethra and it's attempting to void.
Yeah.
And that's a diagnosis of exclusion. You know, you're ruling out all of the other stuff. But then when we're in the position with this dog where we have a dog that doesn't have a clear known cause of mechanical obstruction or functional issue, and we're left over with this, could this be that? And then if I'm in that situation, that's probably when I might be trying trials for medications designed to relax the urethra. So another thing that was highlighted quite nicely in this consensus statement was a little bit about the difference between urinary anatomy in male dogs and female dogs, which was a nice refresher for me because I hadn't really thought about it in
It's
a
really
long
good
time.
for studying for exams.
Yeah, really good for studying for exams. So for anyone's doing memberships and things like that out there, definitely give it a read. But basically for the male dog, we really have the smooth muscle component of the urethral sphincter in that sort of pre-prostatic region, sort of between the bladder and the prostate. Yeah, neck of the bladder.
It's not much.
Not much. And then we've got a whole lot of sort of striated muscle post-prostate. And so I guess from our pharmacotherapy, we've got to think about the fact that there are sort of those two regional differences. Having said all of that, they do recommend starting with alpha antagonist therapy to try and relax the smooth muscle first in these patients. And historically, we would have been thinking about prazosin as probably the most widely used drug that we've got in our arsenal there. Tamsulosin, which is in the same drug family, is kind of the more new, trendy. I would call it trendy one. And actually in this statement, they're like, you know, anecdotally, their panelists thought that this was
I think because prazosin's a little bit out of favour, probably more from the feline perspective, which we're not going to touch on here.
Yeah.
But I don't know. We don't see many of these cases and they don't all respond to the same treatments. So I think it does. It's just a trend.
Yeah, it's a trend. People feel like in their hands that it's more effective. Yeah. And it can be a little tricky in a small dog because you do have to get it compounded.
For big dogs, though, the brand name is Flomax.
Flomax, that's right. So they're really selling it, isn't it?
It's a human drug, for male human prostatic problems. So.
Yeah. So that's one to try. That would be one that they would recommend, or I'd recommend trying in this instance first. And then if we're not seeing improvement with that, then we can obviously add in skeletal muscle relaxants, so things like diazepam, alprazolam, in complement to that. Some dogs, and I've not been in this situation though, again, very few cases under my care with this, they discuss you might need something like bothanicol or something to try and stimulate that bladder wall contraction if we've got bladder atony.
I think that's ones that really have been left undiagnosed or untreated for a prolonged period. So they've had prolonged bladder enlargement, kind of like a cat that's been obstructed. These dogs typically are not obstructed with like a post-renal AKI, but their bladder is dilated like constantly. And they're just getting little bits out. So if it's been going on for a long time, you might not need it the whole time, but just get that bladder contracting.
Yeah, exactly. And if you were dealing with a really severe case, you might need to think about temporary urinary catheter placement to kind of give the bladder a little bit of a break as well.
And that can help with the atony as well.
Yeah, exactly. So I think that's it's a bit different to be dealing, but I guess for this dog with incontinence, because we have the straining aspect, we do have to sort of flip our lens a little bit and think about is this avoiding problem.
Yeah, and I think with this dog, my first concern was that this could be a mechanical obstruction or a moo. So just like saying
so
it.
Silly.
I don't know why they chose it. So like being really sure there's no stone or stricture. So I think I did a retrograde contrast urethrogram in this one as well, just because it's difficult to image that area with CT or ultrasound, the whole urethra, and we can get cystoscopes small enough to go up larger dog male urethras, but it's still not as good as just having that contrast urethrogram where you can see
and it's pretty easy to do. Like they need to be sedated, an important thing is
sedation because you need to clamp the tip of the penis.
Yeah, you do need to basically they don't love that. So you need to make sure that you've got that seal there. Yeah. Another important thing about that study is making sure you've got good bladder distension. Make sure that you really actually fill the bladder, fill the urethra. So it's a diagnostic study.
And get your X-ray as you're injecting.
Yes.
So that otherwise if you inject and then take your x-ray, the urethra will collapse down again because you will have put it all into the bladder.
Yeah, exactly. So, but yeah, that's a good one to do.
Yeah.
Very.
Can be done before. Yeah. I mean, we do a few, but it can be done in GP pretty easily if you need iodinated contrast, IV contrast.
Yeah.
So obviously not barium or anything.
Yes.
It'd be irritant.
Yeah.
But yeah, we dilute at 50-50 and it can get some really nice studies. And yeah, we've a few strictures we've diagnosed with that as well.
Yeah, certainly. Yeah, a few strictures, urethral stones. You would be able to identify. Well, you wouldn't be able to confirm it's a tumour, but you would be able to look for evidence of that as well.
Yeah.
I think we'll probably wrap it up there then.
So urinary incontinence can be fun.
Can be fun. All aspects of internal medicine can be fun.
They're all fun. Everyone's happy all the time.
Yeah.
But yeah, I think there are cases where you can have like a really positive outcome for the dog. You know, the worst cases are the ones with tumours and that, which we haven't really touched on. We've touched on the more treatable aspects of incontinence. But for those younger dogs, often we can, really improve their quality of life and
absolutely.
And owner quality of life, because I think that's something that we often neglect with these incontinent dogs is cleaning up urine all day it really impacts that owner pet bond.
Absolutely.
Yeah.
Well, thanks for joining me for this chat, Susie.
Delightful, Bonnie.
Right, thanks.
Thanks, guys.
And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.